didn't think about is when I'm doing the presentation, the slides are in front of me, so I don't always see hands or comments. So if you will be my actually watching this room, that would be awesome because
Absolutely.
yes, it's easier for me to have the slides in front so that you're not weirdly seeing me turn when I.
Okay, before I hand it over to Dr. Miller, I did want to take just a second to introduce Dr. Lauren Miller. She is an associate professor of clinical sciences at West Virginia School of Osteopathic Medicine, and of course, a family physician at Robert C. Byrd. So welcome and thank you for joining us to talk to us about Medicare annual wellness visits. And before I hand it over to you, I did just want to also let this group know you will see an invite to come for our next month's Lunch and Learn. It will be scheduled for October 23rd. So be on the lookout for that. We're getting the series back up and running for the fall. This group will see more invites to come.
Thank you for that lovely introduction. All right. Is it time to get started?
The show is yours, Dr. Miller. Thanks.
All right. Well, welcome everybody. So usually when you hear staff talk about medical annual wellnesses, it's with groans because they can be complicated exams. They're not something that I learned in medical school. They really didn't really. I don't know that about 15 years ago is when you first started hearing its name. And so it is something that is very different than what other well exams have historically looked like. And so my hope is today that I will help you get more comfortable with utilizing Medicare annual wellnesses within your practice and really helping so that for the providers who are here, helping you see how you could lead your medical team to really make these an efficient service that is kind to your schedule and still gives our patients the highest quality care. So that's what my lecture is called today, is Medicare Annual Wellness Visits, Utilizing a Team Approach for Higher Quality Care. If you are not a physician, this is still a wonderful lecture for you. It can help you see how to, what part of the piece, what part of the team, what kind of player you might fit in to become. All right, so objectives today are pretty standard. We're going to understand the goals of the Medicare Annual Wellness. So I like to say, let's understand the intent, understand the barriers to completing Medicare wellnesses, review actually what they are, what's the components, explore how team-based approach to Medicare Annual Wellness visits can work, and the best methods that can often be utilized in any individual practice. And so I will argue whether you are a huge system or you're a small rural practice, we're going to discuss how this same approach can absolutely be utilized at both places. And then I'm going to hit on, and right, the slides will be made available to you, some of the specialized billing codes and reimbursement for these visits, because they also provide a chance for, income. So there's three types of Medicare annual wellness visits that you're going to hear today. So the first is the Welcome to Medicare Annual Wellness Visit, also known as the initial preventative physical exam. I very much do not like this term because the physical exam, as we know them to be historically, are not is not that. So the term that I would recommend utilizing in your practice is the Welcome to Medicare. They're supposed to be done in the first 12 months that a patient has Medicare. And so it's easy for your patients to understand, all right, I have been welcomed into this program and this is my first visit with it. Then if it's a patient who's already had Medicare for 12 months, then we talk about their first annual wellness visit. And once they've had one under their belt, then it's subsequent annual wellness visits after that. So I like to take just a couple minutes to really describe why I'm passionate about this. So I had a medical student not too long ago work with me, and before medical school, he had a wealth of clinical experience working at different primary cares. And he said, Dr. Miller, I think you're the first doc that I have ever worked with that likes these exams. And so I told him, well, my goal is at the end of your rotation, there'll be 2 of us in the world. And so why I like them. I like them because they even the playing field. So I have practiced in 2 locations in my life. I've practiced in Lewisburg, West Virginia, in southern West Virginia, and I have also practiced in Ashland, Kentucky, which is on the most eastern side of Kentucky, very, very close to the Huntington area. In fact, I never moved out of Huntington when I was practicing there. And boy, because I had worked in Appalachia, both places, and I had patients who had all the social determinants of health, and because I still had some patients who I did home visits that didn't always have running water, I thought I knew rural medicine, even though I was not practicing at a rural location. I had patients that would come in from remote areas. And what I have learned is the amount of services that I could offer in a city that is as small as Huntington, which Ashland's pretty comparable, is, and Ashland's health system's very comparable to Marshall Health. They're night and day. And so the only way that I am ever going to be able to even the playing field is if I don't need some of these specialists in the first place. So if I'm able to catch a condition really early, if I am able to prevent it from happening at all, then I can actually even the playing field in healthcare. I can be in front of the illness. And to me, that is one of the most beneficial. The second is it really allows your patients to form a close bond with your staff. The majority of these visits do not have to be completed by a physician, and I would argue shouldn't be completed by a physician. And so if your staff trusts the MA, CNA, the nurse that is doing the majority of the exam, if they trust the patient service representative that might be collecting some of the data who pitched this to them, then it actually makes the cohesion of the group so much better, because that patient knows, hey, if Dr. Miller I can't speak to them, then I got to know how. I will call the nurse, Peggy. I got to spend 30 minutes with Peggy at my Medicare annual wellness visit, and I know she knows what's going on with me and she can help me. So it can really get a true cohesive team. So studies are starting to show they work. So they were initially implemented in 2011. Medicare patients, and so some of the studies show that those who receive their annual wellness visit within their year experience a 5.7 reduction in their total healthcare cost over the next 11 months. And the greatest effects were seen in patients who have those highest hierarchical risk quartiles. So for the patients who have conditions that can cause some of the gravest outcomes, the highest risk for morbidity and mortality, that's who we're helping most. Adult wellness visits have been shown not to be associated with increase in ED visits or hospitalizations. They're also significantly more apt to receive the recommended preventative care that they need. And so I did quote my source, and so you can see that at the bottom. So what are their goals? The goal is to provide older and disabled patients with preventative health measures to help catch or stop the progression for many health or age-related conditions. So oftentimes, if a patient is not older, so they didn't age into Medicare, disabled patients often have some of the same issues that patients that are elderly have, such as issues with is there the right caregiver in place? Do we make sure that they're not a fall risk? How's their mood, right? Disabled patients are at a higher risk for having depression, which is a part of the screening here. And so the aim is to really look at, can I catch the progression of conditions in this population? So most patient visits, as we know, are focused on chronic diseases, followed by acute care needs. And this really gives a chance to change the conversation and start making coming to the doctor also about creating a plan to prevent future ailments and to keep the ones that we have under control. So it encompasses all three aspects of preventative care. And so primary preventative care is when we prevent a problem from happening in the first place. So exercise and decreasing caloric intake so that no one ever develops obesity. Secondary prevention is where we try to prevent the progression of an existing disease, such as a patient who has diabetes. We spend that time educating on diabetic foot care, an appropriate diet to control blood sugars. And then tertiary prevention is essentially we're softening the blow, right? We're softening the impact of the disease that a person may have. So we're making sure that they have routine eye exams for being a diabetic. We're making sure that they're getting that care. So even if we screen and they have retinopathy, then we're getting them quickly to have it taken care of. So what is it not? So it's not a time that is meant to treat current diseases or injuries. This is meant to be a true preventative visit. Depending on what type of practice you're in, if you're not in a rural health center or an FQHC, you may be able to do a chronic care visit and a Medicare annual wellness visit on the same day. However, these are two distinct separate visits, and the workflow has to be there so that the time is allotted and the staffing is allotted to handle two distinct separate visits. It's not a standard physical. So, a lot of people, when they think of a physical, they think of a PAP, they think of a digital rectal exam, they think of the sports physical that they had in football, or maybe what they got when they were younger as a child. It is not that type of physical. Technically, the use of a stethoscope, which is my little icon here, is not necessary at a Medicare annual wellness. It also should not be a waste of your time. So I have had patients say, I have had patients and physicians say, I don't know the point of these. I really think this is just a waste of time for the patient. And so hopefully, if you truly embrace what it's meant to be and put the right team in place, it will become a worthwhile experience. So just going back to those three types of Medicare annual wellness exams that I discussed before, your Welcome to Medicare is a patient who is eligible for the initial preventative exam in the first 12 months of enrolling to Medicare. The initial annual is a patient who is eligible for this visit a year after their first Welcome to Medicare. Or it's the first time they've ever had it. And then your annual visit is just every year following that. So they're not they're not very different. And I will say one of the things that I've incorporated in most of my practices is that my Welcome to Medicare wellness workflows and what we do are very, very similar compared to what we do when we're doing a subsequent or an annual. So there is a couple of differences. The Welcome to Medicare visits require an eye exam. I mean, can be as simple as just the eye charts where there's marked on our hallway how many feet back. And then an EKG must be offered. Your patient doesn't have to take you up on it. One thing to remember if they do get an ECG, is that if it's abnormal, that won't be free. So these visits, like any other preventative care visit, are without copays. And so if the EKG, which will be free as a part of it, comes back normal, then the workup for that is not covered at 100%. Now, the whole point of it being that we have a very good baseline EKG in the charts for the next 20, 30, 40 years that this patient is alive, or early detection if something is abnormal. However, I think it's important with shared medical decision making that your patient understands that the subsequent things are not considered preventative care. Hearing screen can be offered if patients screen positive for hearing loss. And those are really two of the biggest things. So what can be done, and a lot of offices like to do this, or a lot of providers like to do this, but are not required, is giving the status for your hierarchical condition coding. So this isn't, this patient has type 2 diabetes with neuropathy, and you're pulling it over to adjust their medicines. You're putting it in the assessment to say they are up to date on their foot exam, they've been referred for their eye exam, here is their A1C, it's at goal or it's not at goal, and then maybe the plan is the patient's coming back in a month for you to attempt to get it in better control. It is outside the scope of this lecture today, though, on how these can be incorporated in. We're really just going to look at the absolute requirements. So barriers. So big barriers to these visits is the time that it takes to prep for a Medicare annual wellness visit, the time it takes to complete the Medicare annual wellness visit. Another barrier to these visits is it's absolutely necessary for, if this is not something that's sort of a part of the culture of your health center, to the pitch to explain what these visits are, so patients have expectations of what they're coming to. Sometimes you're selling the patient on why you're coming to the doctor healthy. Support staff. So we have historically, since the pandemic, struggled with getting nursing staff, and this absolutely requires utilization of your support staff to work correctly. And then just one of the things is docs not understanding how to complete all the requirements, and provider what can be completed by somebody else. So at a minimum, the components of your Welcome to Medicare should have the same that should be in your chart already. So this is a chance to really look at, do I have this correct? Is it up to date? Your past medical history, your surgical history, hospitalizations, operations, allergies, your current medications and supplements. So I love to utilize this visit as, let's do a good med rec. My schedulers will do kind of an extra reminder to make sure my patients bring in their medicines. Family history, diet, what are your physical activities, alcohol, tobacco, illicit drug use. And so these should already be there as part of our standard intake. And so it's just Medicare saying, hey, let's check in and make sure this is accurate. Components should also include a review of the patient's potential for depression or risk factors. And so you can select from any major standardized tests. I gave you a link to where you can find all kinds of ones that are associated or that can be used. The one that we use in our clinic, and so this is a screenshot of Athena, which is REHR, is the PHQ-29. We generally just do PHQ-9s for our wellness visits. Technically, you can do a PHQ-2 and then convert it to a 9 if it's positive. So another component is that you're going to review the patient's functional ability and safety level. So direct observation, appropriate screening questions. So you need to look at ability to perform activities of daily living, fall risk, hearing, and home safety. And so again, most EHRs have this set up in a way that allows it to be very templated, allows nursing staff or even support for nursing staff to go through and ask these questions, check boxing, clicking the buttons without any medical decision making. So this is what our activities of daily living look like. Our fall risk screening, we use the STEADY. We do our hearing screening is just as simple as, do you have any hearing loss? And then, or are you wearing hearing aids? And then again, in that welcome to Medicare, if they have screened positive, should be offered a hearing test. Now, you don't have to perform it. Maybe it's a referral to audiology. We do perform a basic hearing test as well. Home safety, this is the template that we use. So is there unsafe flooring? I will tell you, depending on how well my staff knows my patients, not every single one of these questions are asked. So the one on firearms can be controversial, can really get patients kind of up in arms. Medicare doesn't require you to ask specifically. It just wants to see some type of screening for safety. And then if you screen positive for it, then it's a matter of a quick discussion in the assessment and plan that you discussed how. So if the patient says, oh no, I don't have night lights in my hallway, I love a good lighting conversation. So then we talk about the safety of having night lights in hallways and bathrooms to prevent falls. Here's another fall risk assessment. So it doesn't have to be as detailed as the SETI. It can just be fall in the last year, any dizziness. And then if you have, is there a fear of falling if you have not, and so. So the exam, right? So the initial physical. So it's not necessarily, again, the physical as we know it. It's height, it's weight, so you can calculate BMI, or it's getting waist circumference. So they're really looking at, are we making sure that we're addressing someone who is overweight or obese, that we can give them counseling? Are we catching metabolic syndrome and blood pressure? Visual acuity test, and then other factors deemed appropriate based on medical and social history and current clinical standards. So sometimes I add a diabetic foot exam to this. Sometimes I will do a PAP in a disabled patient that is due for one. Sometimes it is medically appropriate to do a digital rectal exam for prostate. Really, it doesn't have to be heart and lungs. Now, if you deem that it's necessary for you, you want to listen to heart and lungs, and I will tell you, I have a lot of patients who kind of feel gypped if they don't have someone use a stethoscope during any of their visits. Um, Sometimes I'll still listen to heart and lungs, but absolutely that is not a necessary component unless there is something that's really compelling you to that. Um, Otherwise, it's really a good place to get some of those preventative physicals. So vision screening, the good old fashioned eye chart, um, or just simply asking, do you have any vision problems? And then are they going to the eye doctor? So we know elderly patients should be screened for glaucoma. We know that even if they say, I can still read fine print, are we making sure that they're still seeing an eye doctor? End of life planning is another component as well. So you can have an extra billing code if you do 16 minutes and actually help them put together a medical power of attorney, a living will. We do have a social worker on site, and sometimes that she does these in conjunction with the exam. We have a whole little booklet that we give that for West Virginia's medical planning, and then a kind of a little handout as just to what it is. One that's a fairly new one is there's sort of been, we were always supposed to be reviewing medications, but Medicare now wants, whether you're the prescriber, the office is the prescriber for an opioid, to make sure that we're reviewing potential for opioid use disorder. And is this working? Do we need to talk to the patient about referring to a specialist or giving them information that maybe the plan of care that they're on is not what they need to utilize? So screening for potential substance use disorders, I mean, this can be as simple as, are you taking your medications correctly, all the way up to different tools that have been established. And I've given you the link for that today. A big part of wellness is education and counsel. Again, ones that are pre-done, such as diabetic diet, foot exam, doesn't have to come specifically from the provider. Nursing can be the one that goes over counsel on smoking cessation, but that must be an essential component of this, is providing where those screens are positive, where counsel is needed. And then there's a plan. The plan should be, was the once in a lifetime EKG appropriate? Place orders for maybe a lipid because of they need their ASCVD risk score, screening for type 2 diabetes, referral for retinal eye exams, or maybe you have a retinal screen. With shared medical decision making, is PSA appropriate? Looking at mammogram guidelines, colorectal, those really should be more of the orders that are placed, unless it's a refill of all my medicines. So the annual wellness visit, whether it be the initial or the subsequent, in actuality is very, very similar and has most of those components that we just discussed, except for the visual screening and the EKG. It also includes something called a health risk assessment, and then should also assess cognitive function. So I will tell you, within our office, even at the Welcome to Medicare, we do we assess cognitive function, and we also do the health risk assessment. We just make it a part of the workflow so that staff doesn't need to know how to discern the two. And then it's ready for us the next year. So we use MiniCog to do our cognitive evaluation. Another, again, what does this health risk assessment needs to include? It needs to include their demographics. It needs to look at their depression. It needs to look at activities of daily living. And so I'll show you an example of it right here. So it's everything we've just done, but then the patient leaves with it. So if you're lucky enough to have Epic, Epic actually does a really good job kind of incorporating this into a plan of care that the patient works with. Where I have Athena, my nurse is who goes down and manually does this before I come into the room. They may ask me if they're not sure. So there's the advanced directive. So we discussed and revised. Maybe we placed in referral to the social worker for overweight. My recommendation today was to lose 10% of body weight. Nutrition's good, follow current diet and exercise plan, physical activity, keep up. It's whatever, and we have different drop-down boxes based on this. So there's your hearing, your independent assessment, your fall risk, your home safety, vaccinations. Do they need screening for osteoporosis? Do they fit into someone who still needs screening for cervical cancer? Is it appropriate to do a pelvic breast exam, mammography, cardiovascular disease screening, colorectal cancer screening, diabetes screening? So it just goes through it all and says, hey, it's up to date, this is great, or this is what we're planning on doing. So a new one that started in this last calendar year was a component to get paid for doing social determinants of health risk assessment. And so this is optional. It doesn't have to be a part of the annual wellness visit, but you can, if you're not on a flat rate, get paid for this, which is looking at limited living environment, access to food, employment status, education and literacy levels, and family circumstances. And then, where possible, attempting to mitigate. And so these are just some of the billing codes. This is not for us to dig through in a whole lot of detail, but these, we call them, your G codes are your E&M for the service. This is not a 99213, 99214, or your previous preventative care codes that you have used prior to getting on Medicare. And then these are the additional codes that can be utilized for the other. It's this patient smoke, and we counseled on tobacco use, was there depression screening, alcohol misuse screening and counseling. And so these are some, and what I do want to show is I did include the modifier for the social determinants of health. Also remember that these can be billed over multiple days. So your nurse might call the day before and get a lot of the data mining. Did you get your mammogram since the last visit? Did you get this? Do some of these screenings. And then the next day is when you do the bulk of the assessment. It doesn't all have to be in that single day visit, which is different than a lot of other visits. So this is just an average on reimbursement. If you really want to look closer to what might be specific to your office, this is the link from cms.gov. But this GO 402, so that's your welcome. Then this is your subsequent annual, and then you can see where there's different tacked on things that add to it. So these really, for the time that it can take to put them in, will reimburse higher than a lot of other visits. So there are literally not enough hours in the day. So one of my absolute favorite studies that have come out in the last decade was research that was conducted through the University of Chicago Johns Hopkins University, the Imperial College of London, that tried to work out how many hours in a day does a primary care physician need to work to accomplish all the national recommended guidelines for preventative care, chronic care, and acute care on the standard patient panel. And they determined that you would need to work 26.7 hours in any given 24-hour day to actually adhere to all of this. And so this was their breakdown. You would need to spend 14 hours a day on preventative care. You would need to spend 7.2 hours a day on chronic care. You would need to do 3.2 hours on your acute care. And then I think they could be lowballing this a little bit. Documentation and inbox is another 3.2. So then the article looked at, what if we did a team-based approach, and everything that insurances, CMS allows another person to do, how many hours in a day would a doctor need to work to get everything done, including their notes? And they took it down to 9.3 hours, which is still not an 8-hour workday, but can physically be done by any given provider. And becomes significantly more manageable than not having the existence of hours when we look at 26. So we get all of these done, and this is where I really get into talking about this interdisciplinary team by having physician's assistants, CNAs, medical assistants, licensed nurse practitioner, or sorry, LPNs, social workers, diabetic counselors, patient navigators, care coordinators that can really help decrease the time needed to give you this comprehensive care. When you utilize this interdisciplinary team-based approach, they have been shown to increase patient buy-in. I am so sorry. Woo. They have been shown to increase patient buy-in and compliance to the treatment plan. And despite the fact that patients often state in surveys that they don't get enough time with their doctors, when a practice actually utilizes more medical teams where doctors spend less time with their patients, but they're getting their needs addressed, patient satisfaction will increase. All right, so this is sort of my all hands on deck graphic that we made to sort of help show you what can be done by different departments. So what can scheduling staff help with? They can determine who's eligible. They can be the ones that, of course, schedule the appointments. They can assist with expectations as to what these visits will entail. They can go ahead and make sure that a patient's scheduled for their next year's visit before they leave from their this year visit. So I like to always say, unless a patient is planning or is planning to move, or there is a risk of imminent death, so maybe they're a hospice patient, there should always be at least one visit in their chart at all times, and that's their wellness exam at any age. And if they have chronic conditions, then depending on it, 2, 3, 4. Who can also assist with this? Care coordination. So review patients' records to ensure that we've already got the information logged correctly. So, right, did their mammogram come into their inbox, but it wasn't recorded correctly in their EHR? So this is what we call in our office data mining, making sure that if colonoscopies come in, if they've seen their podiatrist and had a thorough foot exam. And so oftentimes what our workflow is in our office is that all of our providers have someone that they are supposed to send any quality metric to that is not a part of, that is not immediately incorporated into our EHR, to our care coordination staff. But this doesn't have to be care coordination. This can be a nurse that's assigned to it. This can be a patient service representative or a navigator, someone in reception that just knows how to take that document and make sure that it's categorized in a way that it then gets incorporated into the note, that it sort of, if you've got an EHR like mine that sort of highlights in red they're due for something, it gets that off of there. They're making sure that when that comes in, it clicks the box. This process that we've done for our providers, where they have someone to immediately punt it to, that will call a patient back if they were the one that ordered it and go over the normal results. Will just simply data mine it if it was done completely by someone else, by a specialist. It's really raised our provider satisfaction, because now they're not spending time just making sure things are clicked right or in the right place. So nursing staff or any type of clinical support can do these initial screening sessions. They can review the patient's records with them. They can do patient education and preventative care plan. So they'll go over what their risk factor is, or what tests they might have screened positive for. They can also ensure that there's a correct and comprehensive chart. And then where's the providers come in? So you have to address or do the medical decision making on what to do for addressing a positive screen. So if someone is got a blood pressure of 210 over 110, right? Whether they're there for a Medicare wellness or they're there for something else, we often have to stabilize that patient who's got something that is could cause imminent risk of danger. But let's say they screen positive for an increased ASCVD risk score and they're not on a statin, then that's where you may say, we'll discuss this next week or next 2 weeks at a follow-up appointment to address this condition there. Review the preventative care plan and make sure that it is accurate. Choose the correct billing code. There it is. That's what the doctor needs to do. I like to say that if they're done correctly, I come in, I give my patient a big hug and I say, oh, thank you, Aunt B. I'm so glad that you agreed to have your DEXA scan and your mammogram. My nurse has gotten everything else up in your chart. How's Andy and Opie, right? It's a very quick conversation where I am just hitting some of the highlights and I am in and out within minutes if it's done correctly, and my note is completely done for me. All I have to do is sign the orders and tee it up, or potentially add a few more things if there was more intense medical decision making. But for the most part, because it's sort of a system in our office, most of the time before I even walk into the room, if patient is positive for a PHQ-9 and they're not imminently in danger, they will have already told me they've made their follow-up appointment with them in 2 weeks to address their positive depression score and to discuss getting on medication. I don't even have to say, schedule that on your way out. A lot of times that's done before I walk in the room. And then, oops, sorry. Your billing and your business department hopefully is reviewing your documentation to ensure that the proper billing and coding has been done. So how do you change a culture that's never done this before? Every member of the team has to understand what is valuable about it and what their piece of this is to do. So it does take some upfront education. We did at our clinic, and we're really scheduled to probably do them again. We cycle every few years, every level of team member that touches the patient has a lunch and learn, very similar to the one I've given you on what can they do to be a part of this team. Soliciting appointments is important. So what we mean by that, maybe having someone set up that when the patient comes in for something else, they're talking to them about the importance of getting this scheduled. Helping educate the patients about what to expect, and then really helping the patient understand and having a little pitch on the value of preventative care. And so, yeah, sometimes it does come from me, but I will say if it starts at my receptionist, then my nurse brings them in and says, oh, I see you're seeing Dr. Miller here for hypertension today. She'd also like to schedule you a well visit. And I see you didn't do it with the receptionist. She gives her pitch again. So my receptionist is given a pitch if everything's going correctly. And they went, no, I don't need that. Then she gives a pitch. And then if she doesn't get it, she actually tees it up for me and says, hey, Dr. Miller, here's the reservations. And so I'm only ever pitching it to someone who's reluctant on the other patients. So it really minimizes how much time I'm in the room pitching this. When it's being done at all the different steps of the patient being touched. All right, so the takeaway today, these really should be a group effort. Everyone in your practice really has to understand their benefit. So if you've got somebody who is a scheduler that says, yeah, Dr. Miller wants you to have this preventative visit. I don't know what it all is. I know she doesn't use her stethoscope. That doesn't work as well any day of the week as someone who is there going, yeah, I had a lunch and learn on it. It goes over your screening tests for cancer. It looks at services that are in place for you. It can be really beneficial to your overall health. When they're pitching it like that, it goes a long way. And then if you're able to we have little pamphlets on what Medicare wellnesses are, but any kind of education that you can create for your patients to help educate the population is helpful as well. So that's my lecture today. These are the references that I used, and so I tried to save a little time for questions if anybody has any. And so does anybody here have any questions for me?
Hey, Dr. Miller.
Yeah.
I have a question for you. And I know we've got some folks from coding on the team as well. So when we do our Medicare wellness, we do have a mini cog and it's built into our EMR. We're always scanning the clock. We have them do a paper clock, and we have them do a paper mini cog as well. Is that required? Or is it just the screening simple mini cog that's built in? Is that sufficient?
So the mini cog that if you're doing, so the mini cog assessment is a standardized assessment that has the clock built in. So they have to draw the clock. You could look for another assessment that doesn't involve a clock. But yes, if you choose to do the mini cog, which is standardized, then yes, the clock needs to be added.
Perfect. Thank you.
Any others?
Dr. Miller, thank you so much. I had one quick question. So you are very clear, and I think it's so important to note just, the overall team approach to this. The research proves that there's simply not enough hours in the day for any one of us to do any of these pieces. A lot of our practices do struggle with turnover in certain areas of the clinic and things like that. How have you been able to support your staff in your practice at large when you do see that turnover?
So we have built into our any of our nursing positions, so CNA, MA, LPN, RN, it's built into the orientation before they can work the floor, are how to do a Medicare annual wellness. It also, and I have a handout for it that they can utilize, and have with them, that they'll keep forever, so they can have it. I actually see in some of my new nurses, they'll have it slid under their computer, looking at it for pre-visit planning. And so it's just a part of our checklist with orientation. So just as you would make sure that a nurse is comfortable with injections and workflow, we make how to do the annual Medicare wellness part of our nursing staff orientation. It's also a part of care coordinations orientation, because it's so vital to get all of this into the chart. Now, where I said we're probably due for some again is scheduling and reception. That one, it's not built in how to do it. And so periodically, when we've noticed we've had a high amount of turnover in scheduling and reception, either myself or one of the providers who, if you saw in there in the beginning, Dr. Chelsea Fager co-wrote this with me, will come in and do an education session. And I don't think we've done one in a couple of years, because oftentimes now that it's become much more part of our culture here, and we're still not where we need to be, but we're getting much better than when we started. That's just a part of what the receptionist will help with our staff when they're bringing them on. It's not quite as structured as the nursing orientation. They actually have a checkoff where they have to complete a Medicare annual wellness with one of our staff from start to finish before they're done with their orientation. But for our scheduling and reception, it's a little bit more of a casual orientation to it, with a periodic little refresher that's in there.
Thank you for that. And there is a question that popped up in the chat. Julie Smith, her mic isn't working, but she had a question about Hep C screening. Will that be covered by preventative if we do the screening during?
Yes, it's a mandated part of the Affordable Care Act to include hepatitis C and HIV. So it goes with those U.S. Preventative Task Force grade A screenings. And so as long as it fits within the guidelines that is set by the Preventative Task Force, then yes, it is included.
Okay, thank you. And then a follow-up to that is on their template, they ask about AAA screening. Is that a requirement for this visit?
That's a good question. You would still be able, if you were not ordering those AAA screens, I don't think that it would be fraudulent for you to send it out. It is a part of ours. If you have a smoker who fits in the U.S. Preventative Task Force, we do order it as a part of it, or denote whether or not they need to have it addressed, or it's been addressed. So it is a part of our workflow. We have a part of our workflow, all preventative care for the patient's demographics, and then we'll go in and click, like for the AAA screen, it's only our assigned males at birth who have this built into their preventative care. And so then we'll either write not applicable, completed, or ordered in regards to that one. And we do have one that is, so ours do differ in templates by, we don't do anything different with age. We have we have a assigned female at birth and an assigned male at birth. And when we are taking care of a transgendered patient who is on Medicare, which we do not have a lot, then we just have to know which things they need and what they don't. It's the only thing that's not templated now, because it's very specific to what treatments that patient has done for gender affirmation.
And for the AAA, is that covered for both men and women?
It is not covered for women.
Okay.
So if one of the things that is very valuable is looking at those quality metrics for your office, looking at these and pulling the U.S. Preventative Task Force to know when to stop offering and what to do. And so if you're a provider who hasn't looked at your U.S. Preventative Task Force in a while, it is a smart idea to go in there and look at it. That'd be a fun lunch and learn, going over all the different, the top preventative screenings that are a part of our quality metrics, and looking at who should get them and who shouldn't.
We're always looking for more ideas.
But that is, it's U.S. Preventative Task Force is what they must go by, CMS, to pay for it. So if it is within U.S. Preventative Task Force, then it's going to get paid for. CMS.gov also has, you can also get on there and it's the same, but they have the criteria for what they pay for as well. And if it differs, it actually sometimes broadens it a little bit, not narrows it.
That is all the questions that I'm seeing in the chat. So I'll give a few more minutes if there's any other questions for the group for Dr. Miller. I'm not seeing any others pop up. Dr. Miller, thank you so much for your time today. I always enjoy your lectures. I've had the privilege of sitting in on a couple so far. And I just feel like you do a wonderful job of bringing it all together and relaying the why this is important and who can do what.
Yeah, well, thank you so much. And thanks everyone who came out and attended. I truly appreciate you. So thank you so much.
Thanks, everyone. Have a good day.